So, good evening, students. Today we'll be discussing about brachial plexus and clinical correlative neuroanatomy and electrophysiology, and we'll be talking a bit about needle EMG examination also, so that the first years DNB students and others can benefit. I request you to take a pencil and pen and try drawing the brachial plexus and the due course of the lecture. What purpose does a complicated structure like brachial plexus serve? Last time we have discussed in lumbosacral plexus also same thing, that is diffusion of risk. Injury to one nerve or one nerve root will not paralyze the entire limb. So the easy way to remember is that you make a mental note of RTDC, roots, trunks, divisions, cards, and nerves, and you can see there is a bit of symmetry that is seen. There are three trunks, three divisions, three cards, and five roots and five nerves. So it's easy to remember, and the trunks, upper trunk, middle trunk, and lower trunk, the cards, lateral card, posterior card, and medial card. So the C5, C6, C7, C8, T1, that's how these will be divided, and C5, C6 will join to form the upper trunk, C7 continue as the middle trunk, C8, T1 will continue as the join to form the lower trunk. And all the divisions are anterior and posterior divisions, and all the three posterior divisions will join to form the posterior cord, and we'll learn it in due course of time. And the important nerves that are in the upper limb are musculocutaneous nerve, median nerve, axillary nerve, radial nerve, ulnar nerve. The sensory distribution or sensory innervation of the nerves, and the nerves originating from uh, the brachial plexus will help us in localization, so very important. There are some are called root collateral nerves, or CNS. Root collaterals are nerves that originate proximal to the brachial plexus, and they usually supply the trunk muscles also. So the involvement of the root collateral muscles will help us in localizing the lesions, which we will discuss. So symmetry is good for diffusion of the risk. So we have, as I said, C5, C6 is upper trunk, and this will give rise to C5 upper trunk will give rise to anterior and posterior divisions. The C7 is a middle trunk. Again, it divides into anterior and posterior divisions, and C8 and T1 it is again lower trunk and anterior and posterior divisions, and all the posterior divisions will join to form the posterior cord. And most of this looks very familiar, but whenever we have to deal clinically it becomes very confusing. So we'll see the posterior cord muscles can be remembered as star, that is subscapular nerve, which supplies the subscapularis and teres major. Thoracodorsal nerve supplies the latissimus dorsi. Axillary nerve supplies the deltoid and teres minor. And radial nerve supplies all extensor muscles distal to the shoulder. So the star can be remembered as a mnemonic for the posterior cord. And the shoulder adduction and internal rotation is by subscapular nerve. So our patients come with this type of complaint, that what is happening, and shoulder adduction and external rotation, shoulder abduction and external rotation, extension of the fingers, wrist and elbow. So weakness in these areas should make us think what muscles are affected and what nerves are affected. So this is the clue to our clinical acumen, which we have to develop slowly, and this is the same thing which we have studied. So C5 biceps brachii and brachioradialis are the indicator muscles for C5 and C6. C7, C8 is triceps brachii. Some of the important muscles which we have to remember, because EMG we have to plan whenever we do nerve conduction studies, and nerve conduction studies in upper limbs will test only C8 and T1. If you remember that, we'll do only abductor pollicis brevis, and we usually test the median nerve and the ulnar nerve, but the proximal roots are not tested, so EMG is very important to get to know that. So all extensors distal to the shoulder are innervated by radial nerve, as I have already said, but supination requires some extension. So supinator is also innervated by the radial nerve. So there are no extensor muscles in the hand, so there are only tendons. And the beat muscles in the upper arm, the brachioradialis, extensor carpi longus and brevis, anconeus, triceps brachii, these are the muscles supplied in the upper arm by the radial nerve. So you can easily remember. So the one is a star, then one is a beat. Uh, Radial neuropathy at spiral groove. It's which is a very common thing which we can see, and most common sensory loss is restricted to the hand and distal forearm. There will be weakness of extensors that space the triceps brachii, and superficial radial neuropathy least common, and pure sensory loss over the lateral hand. There is no motor weakness, all reflexes are normal. So some of the salient features which we'll be again discussing when we discuss questions. So please try and remember what we are saying, because there will be around 24 questions which we can interact. So musculocutaneous nerve, the brachialis, biceps brachii, and coracobrachialis, and it has got a sensory component also which will supply the lateral arm. So the forearm, if you look at the flexor compartment, which is generally median nerve domination. The middle of the upper extremity, they start the muscles, generally control the median nerve. Pronators also engage in flexion. So any muscle with word pronator is innervated by median nerve, except two exceptions. So it is ulnar half of the flexor distorum profundus that flexes the distal interphalangeal joints of the digits 4 and 5, and flexor carpi ulnaris, which are supplied by the these are the two exceptions which supplies. The median nerve in the hand is a loaf muscle. So the loaf muscles are the lateral two lumbricals, and opponent's pollicis and abductor pollicis brevis, and flexor pollicis brevis, which has got a dual supply from ulnar as well as a median nerve. And we know that medial nerve syndromes are there. We are very much familiar with carpal tunnel syndrome, where objective sensory loss, the indication is tip of the index finger will be showing objective sensory loss, either index finger or middle finger, and the tip will be the palm cutaneous sensation is normal, as palmar cutaneous nerve peels off before the carpal tunnel. There is no forearm or sensory loss. So whenever you present with carpal tunnel syndrome, which we will discuss in due course also, you first test the sensation at the tip of the index finger or the middle finger, and palm of no use, because already the palmar cutaneous band peels off before the carpal tunnel. The ulnar neuropathy is more common. They're most common at elbow. What happens in ulnar neuropathy is there is a sensory loss of a dorsal and volar hand surfaces. Dorsal, the ulnar neuropathy at Guyon's canal is less common. Sensations, but we will discuss one question about this in the question answer session. The sensation of the dorsal hand surface is also spared in this. So we have to differentiate all the mononeuropathies from plexopathy or radiculopathy. One key point is sensory loss or the medial forearm is not due to ulnar neuropathy, but is either lower trunk plexopathy or C8T1 radiculopathy. So we have to carefully examine the medial aspect of the forearm. If that is involved, it's not ulnar neuropathy anymore. So when we differentiate mononeuropathy from plexopathy and radiculopathy, again we'll address this issue. So the median nerve, which is visible here, and the ulnar nerve. So we have median, ulnar, and radial nerve distributions in the hand. Now there is some importance about the cutaneous sensation of the forearm and hand, which I tried have already elucidated. The hand is the terminus of the three main sensory nerves: the radial, median, and ulnar. If you ask what is the area for radial nerve testing, it is the first dorsal space on the first dorsal interosseous muscle, that is for the radial, and the tip of the index is for the median, and the tip of the little finger is the ulnar. So these are the sensations, whereas the forearm sensation by antebrachial cutaneous nerves, the medial antebrachial cutaneous nerve and the lateral antebrachial cutaneous nerve. When we start drawing the diagram of the brachial plexus, which is when coming in the next few slides, then you will realize how easy it is to remember them. The cutaneous sensation is depicted here. All areas distal to blue line, this is the distal line, and medial to the blue arrow are median nerve territories. This is distal and this is medial, and this is the ulnar nerve territory. So this is a radial nerve territory. So you can remember this by looking at the diagram, and which you should give. So now we'll start drawing the diagrams, and which has got a very good reference, and it's very easy for students who have not seen this. For those who have seen this, it's a revision, but it contains neural connections between neck and brachial nerves. So this PD method helps simplify understanding the diagram of brachial plexus. So all of you draw two headless arrows to the right. So you can see that there is a headless arrow here, and right. Draw two headless arrows to the right. Okay. Now add a headless arrow to the left also. You see the left side. You can see the next. And add a W at the end. So this is the third diagram which we are drawing, and add an X in between. So two headless arrows to the left and to the right, and one headless arrow to the left, a W and an X. That's I hope you all of you have drawn this. Then just one branch of Y is added. So this is the diagram which you will memorize, and then you can easily construct the brachial plexus. That is C5, C6, C7, C8, T1. So now we are labeling the roots which we have labeled, and now we'll label the nerves in the W. That is the muscular cutaneous nerve, the median nerve, the ulnar nerve, the axillary nerve, the radial nerve. Now it is easy for us to see what fibers are carried in the what nerve in this fashion. So this is the next important diagram which you have seen, C5, C6, 7, 8, T1. Now we have to now apply the main branches and main nerve roots. The proper connections are shown here. That is the radial nerve, axillary nerve and all. The diagram will become more complicated a bit now. More complex diagram of the brachial plexus includes the 4 threes, and we know 4 threes. Neurosurgeons, neurologists, and psychiatrists or physicians, they all will use this diagram system. Now you see what are we going to do now. Now we are going to draw the first 3 is the branches to C5, C6 and C7, which will form the long thoracic nerve. This is the long thoracic nerve. It is easy to remember this way, and we have already drawn this diagram to some extent. Now we'll go ahead. After what will you do? The second 3 is in C5. You see one here, one here and one here. And what is the dorsal scapular nerve and the lateral pectoral nerve, and now to subscapularis and so suprascapular nerve. So suprascapular nerve, dorsal scapular nerve and the lateral pectoral nerve. So the next 3, we are going to have 4 threes, and this is the second 3. And the third 3 is coming here, and what are these? Thoracodorsal nerve, upper subscapular, and thoracodorsal and lower subscapular. So there are 2 subscapular nerves here and thoracodorsal nerve. So this is the third 3. First 3 is the long thoracic nerve of C5, C6, C7, and the second 3 is dorsal scapular nerve, suprascapular nerve, and lateral pectoral nerve. And here comes subscapular, thoracodorsal, and 2 subscapular nerves are there. Here comes the cutaneous, the C8T1. We have the last three that will give us the medial antebrachial, lateral antebrachial, and see, you see these are the cutaneous branches: medial brachial cutaneous, medial antebrachial cutaneous nerves, and medial pectoral nerve. So these are the three branches. So now we have all the nerves in the brachial plexus shown here. And so you can see that first we started drawing the arrowheads without a head, the arrows three, then we constructed the W, then the X, then the Y, then we started putting 4 3s and completed the diagram. Now comes the next part. We have to divide into roots. These are the trunks. These are the divisions. There are no branches from the divisions. If you see, all the three posterior divisions will come, they form the posterior cord, and the anterior part of the middle trunk and the anterior part of the upper trunk will form the lateral cord. So then similarly you have the medial cord formation, which is a low anterior division of the lower trunk, as that will be continued as the medial cord. So these are the roots, trunks, divisions, and cords, and this is in short the brachial plexus diagram, which if you are asked in the exam, you sometimes it is asked in the exam and you'll have to draw this diagram, and then your life becomes very easy to learn this. Okay, this is a compact brachial plexus diagram, right? So this is by Dr. Daniel Roman, and the physical medicine specialist, and they have done an excellent job, and we have all been following this. Now, well, let's come to the electrophysiology of the brachial plexus. And in general, what is electrophysiology? What we do, we know sensory nerve conduction studies, motor nerve conduction studies, and needle EMG. And after doing nerve conduction studies, why should we do EMG? That's a question which we'll try and answer. And what are the we'll go a bit deep into needle EMG in this class, because I didn't cover it in the last lumbosacral plexus class. So the nerve conduction studies are conventionally, the motor nerve conduction studies is the median nerve that is being shown here, which is having a compound muscle action potential, which is shown here. And of course the sensory nerve action potential is shown here. That's also a median nerve, which is dorsal root ganglion. The beginners should remember that this dorsal root ganglion is very important, because lesions are either preganglionic or postganglionic, and that's how we differentiate from the plexopathies. So when we do EMG, we'll do at a muscle at rest, and then we look for insertional activity, spontaneous activity, and with voluntary contraction, and we do MUAP studies and recruitment, and we study the motor unit morphology, which will come to that place again. So insertional activity, normal spontaneous activity, abnormal spontaneous activity. The muscle during activation, we put a needle and see mild effort, what is the MUAP, moderate effort, what is the MUAP, and full effort, what is the interference pattern. So just we'll try and understand what is the what you are seeing all this, and these are all muscle fibers. These are all muscle fibers. You put in a needle, and this needle is measuring these 2 or 3 fibers and giving you this motor unit action potential. So the amplitude of this MUAP is by these, all the white fibers are all these are all the muscle fibers of same motor unit, but they are not next to one another, they are distributed, and this needle is picking up potentials from all the motor units, and that gives you the duration. So amplitude is given by the fibers that are nearer to it, and the duration is given by the scattered motor unit fibers, and that's the understanding. So you look at this, these are the motor fibers, and this is a motor axon, and it is supplying various fibers, and this is the typical motor unit anatomy, and you have got myofibrils, and they are the branches of the motor axon. So why to do EMG? See, your nerve conductions are limited in the upper limb C8T1. That means you are not assessing C5, C6, C7 to any extent, because you are doing only the C8T1 assessment by doing median and ulnar. In lower limb, similarly L5S1. We choose different muscles to determine a root level. Same root level, different nerves. So we should understand what are the muscles which we have to select for a particular root, or what nerves are giving supply to muscles which are from different roots. Then the paraspinal muscle involvement is present or not. That will help us in deciding whether that's a root lesion or not. And compressive and entrapment nerve lesions also choose different muscles to determine a nerve involvement, and determine whether lesion is affecting myelin or axon or both. And compared to nerve conduction studies, this will help us also. So what is the third age of the lesion? When you do EMG, FIPS, polys, and so what are FIPS and positive waves? They are acute more than 3 weeks, and I'll show you some. We'll talk about this in the next couple of slides. Polyphasia, that means if the amplitude is crossing the baseline number of times, then that is called a phase, and polyphasia occurs within 2 months. It's a chronic occurrence. Long duration means it is at usually 6 to 8 months. So by looking at the motor unit action potential, we have so many things to learn, whether on spontaneous activity. If you see FIPS and positive short waves, that nerve injury would have taken at least 3 weeks ago, right? Before 2 weeks, nothing is visible. So we do this insertional activity, spontaneous activity, normal, abnormal, mild effort, moderate effort, and full effort, which I have already shown you. And insertional activity starts as you insert a needle into the muscle. You should stop, and it should become flat when you stop the insertion. This is a normal insertional activity. Sometimes the needle touches what we call the end plate. This is the end plate. So this is the end plate where the branch of the axon is landing on the muscle fiber. That is the end plate, and that end plate noise is also something encountered when the needle is near the nerve entry point into the muscle. It sounds like a seashell noise, and it will not stop unless the needle is removed, and it looks like it can be painful too. So this is the end plate potential. This is also insertional activity. So you just adjust your nerves. Then the insertional activity can be abnormal, and fibrillation potentials and positive short waves, which are shown here. And here the positivity is on the downside and negative is the up, and seen early, typically 3 weeks after the lesion. It's not painful and does not stop if you pull the needle away from it, and it fires regularly. So as you put the needle, you also look for spontaneous activity, but you ask the individual to relax totally, and no contraction should be there when you study the insertional activity, and that's very, very important. And motor unit action potential will look for amplitude, duration, and phases. And as I said earlier, this needle will only catch the action potentials of these 2 or 3 fibers in the normal muscle, and that is reflected in the amplitude of the MUAP. And if it also causes the electric potentials from all the fibers of the motor unit, that will give you the duration of the MUAP. And the phases are when the amplitude crosses the baseline. It has to cross the baseline, then only it is called a phase. And so you look at the amplitude is this, the phase is it has to cross the baseline, and the turn is not a phase, it has to cross the baseline, because the polyphasia is seen in chronic nerve lesions, and that's very important. So this is the amplitude, this is the phases, this is the duration, and the duration also increased in more than if the injury is 6 to 8 months. So the amplitude, the duration, and the phases will help us. For example, in if it is a myopathic EMG, then you have low amplitude, polyphasic, and complete interference pattern in the EMG. So the neurogenic EMG, now you see that here the muscle fibers, what happens is the nearby axons also will start innervating. Now you see a grouping has taken place here. This is now more than one muscle fiber That is, there are groups of muscle fibers from the neighboring motor units also are grouping together. That's how you get the polyphasia, and in the this is called a neurogenic EMG. So these are the whenever the denervation takes place, the adjacent axons, neurons start tweaks start supplying the muscle fibers, and they all come together. We earlier diagram we have seen that all these fibers are scattered. Now they are getting grouped, and that's what causes the polyphasia. And so now MUP is seen after activating the muscle. You ask him to contract slowly, and typically MUP has got 1 to 3 phases. A number of units go up as the effort is increased. That's called recruitment. It needs to be observed mild, moderate, and full voluntary effort when we can see the interference pattern also. And in chronic, what happened, I already told you, in chronic nerve injury there will be 4 to 5 passes, as you can see, and sounds thundery on screen. And more recent injury, as I told you, you'll have polyphasia. That means up to 2 months. And long the old injury, it's a long duration like this. It will happen long duration, and polyphasia are seen in the abnormality and the MUAPs. So that's how we finished the EMG. Now we're going to break here. How to differentiate mononeuropathy from radiculopathy or plexopathy at bedside based on history, motor, and reflex findings. As the same thing applies. The plexopathies are common with trauma or cancer, and rarely diabetes will cause radiculoplexopathies. So one nerve territory mononeuropathy, that is weakness outside one nerve territory, can never be mononeuropathy. So you should know the nerves and the muscles they supply in completely. Common cause of more than one nerve territory pathology is radiculopathy. May be combined with plexopathy in severe trauma and diabetes. The plexopathies are by and large uncommon. Infiltrating cancer or its local treatment with radiotherapy can cause plexopathies, and severe trauma can cause plexopathies. And so, how do we differentiate? And not a mononeuropathy if there are two reflex abnormalities, except for proximal radial neuropathy, when you can have more two reflexes. Objective sensory loss on hand and contiguous forearm, that is not a mononeuropathy. I have already told you that median nerve or ulnar nerve, if medial part of the forearm is having a sensory loss, it can never be mononeuropathy. Objective sensory loss over the entire hand is not a mononeuropathy. Objective sensory loss that crosses the midline of the forearm or arm is not a mononeuropathy, and it is a radiculopathy or a plexopathy. Whenever you suspect a mononeuropathy or brachial plexopathy is suspected, we'll have to get a CT MRI done. Mononeuropathies manifest abnormalities confined to one nerve territory. So you should know what are the abnormalities that you can see with radial nerve, median nerve, ulnar nerve, and their branches. And you have to study what is the anterior intraosseous nerve, what is posterior intraosseous nerve abnormalities. And it is conceptually realized that cervical radiculopathies are more common than mononeuropathies by and large. So if you have a wrist flexion, pronator has a secondary function of flexion also. So it is either radiculopathy or plexopathy if you encounter this. Wrist extension has a secondary extension of a supinator also. So whenever such things happen, it is not a mononeuropathy. So mononeuropathy is unlikely if you have this type of presentations where you have weakness in supination and extension flexion combinations. So unlike weakness above and below shoulder is due to brachial plexopathy or radiculopathy. See, weakness in the whole hand or a weakness above or below shoulder, it is always, if you see above the clavicle and below the clavicle, if you have the problems, then it is never a mononeuropathy. It's always a plexopathy. Okay. Combined weakness. So the root collateral nerves, dorsal scapular nerve, which supplies the rhomboids, and levator scapulae, which is the you should know how to examine these muscles and rule out the involvement of the root collaterals or RCNS nerves, which are coming from the C5 and C5, C6, C7, as we saw in the diagram, long thoracic nerve, serratus anterior. Unfortunately, this exam, when I went to Bombay for examination, People didn't know how to examine serratus anterior. We had to coax them to tell how to examine serratus anterior. Please remember, you have to know how to examine serratus anterior, rhomboids, and infraspinatus, and the shoulder abduction. All please go on rehearsing them, and it will be asked in exam. You have to show how you test the latissimus dorsi also. The posterior primary ramus, and the last time we were discussing the paraspinal muscles, root collateral nerves. Again, one important aspect, how the brachial plexus is formed. The the spinal nerves, the dorsal root, ventral root join to form the spinal nerve, which will come out through the intervertebral foramina, and it immediately divides into posterior primary rami, anterior primary rami. The posterior primary rami supply the paraspinal muscles, and anterior primary rami join to form the plexus. This concept please don't forget, because that's very important. That's how paraspinal EMG is done, to see whether there is any denervation pattern, whether there are any FIPS or positive short waves, and nothing else can be done in the paraspinal muscle. Just put a needle and see whether insertional activity is normal, abnormal, and where there is any spontaneous activity. That will help us. So radiculopathy, plexopathy, plexopathies are usually associated with sensory loss, and when you do sensory nerve action potentials, they are not seen, whereas radiculopathies will have normal sensory nerve action potential. So snaps, elicitation of snaps is very important, and every one of you should do nerve conduction studies and now and then at least, and to see whether snaps you are able to, because snaps is a bit a difficult task to get, and right. So as I was explaining to you that dorsal root ganglion, dorsal root, and you see the snap, and radiculopathy, the snaps are normal, and there may be a drop in compound muscle action potential when motor neuron undergoes Wallerian degeneration in radiculopathy. So C5, C6 radiculopathy is the most common. The snaps are always normal in radiculopathies. And then they may be, as I said, Wallerian degeneration, CMAP may be abnormal. And insertional activity appears 2 to 3 weeks later. So in the first 2 weeks, and you will not have any abnormality. So you should remember that the FIPS and the positive short waves, they appear after 3 weeks, that is the acute insult. How is CMAP amplitude affected in plexopathy and radiculopathy? In what condition CMAP amplitude is preserved? Anybody can answer this question. How is CMAP amplitude affected in plexopathy and radiculopathy? In what condition CMAP amplitude is preserved? Anybody would like to answer this question? Taking some. Are you all there, or you're all sleeping? Is it? Anybody can talk? Yeah. Yes. Yeah. Yeah. That's it. That's it. Yeah. Yeah. That's nice. Okay. Reduced sense in plexopathy and radiculopathy can be preserved in anti-horn cell disorder. Okay, right. So let's see. Radiculopathy, usually CMAP amplitudes are usually preserved. In radiculopathy, complete loss of axons is very rare. Most muscles are supplied by more than one root, and there is also a sprouting, which collateral sprouting, which will give rise to polyphasia, which I showed can happen. In plexopathies and mononeuropathies, there is more of axon loss, hence the CMAP amplitude is lost. So that's a simple question which we should go on to. So radiculopathy snaps are normal, EMG is abnormal in more than one nerve territory, so you should know where to do the EMG. C8T1 radiculopathies may be associated with reduced median and ulnar CMAP amplitudes. Paraspinal muscles and muscles supplied by root collateral nerves may be abnormal on EMG in radiculopathies. And these are the 4 points for you to understand about the radiculopathy and electrophysiology. Right. Plexopathy, snaps as well as CMAPs are both abnormal, which we have already discussed, because it's the So whenever you give a report, either you should mention a pre-ganglionic lesion or a post-ganglionic lesion, looking at the SNAP and the CMAP amplitude. Then what is the importance of assessment of cutaneous sensation, which entrapment neuropathies may also coexist with cervical radiculopathies. The sensory cutaneous nerves are never compressed. So the lateral antebrachial cutaneous, the superficial radial sensory, the medial antebrachial cutaneous nerves are very, very important. Involvement of sensory potential suggests that it's a brachial plexopathy, and you should know very carefully, you should test the forearm sensation in your peripheral neurology cases. And in plexopathy, primary posterior rami are normal, so paraspinal EMG will be normal, and root collateral nerves are also normal in cases of plexopathy. So we learned about neuropathies, mononeuropathy we'll study. We have covered radiculopathies, we covered plexopathies. Here snaps are abnormal, EMG is abnormal in more than one nerve territory, and paraspinal muscles and muscles supplied by root collateral nerves are normal on EMG in plexopathies. So if you want to chart out the plan for upper limb EMG, first dorsal interosseous muscle has got ulnar C8T1 roots, and C8T1 root also has median into which supplies the abductor pollicis brevis. So C6, C7 roots, median nerve, flexor carpi radialis. The brachioradialis, it is radial C5, C6 roots. Triceps, radial C6, C7 root. Deltoid, axillary C5, C6 root. And cervical paraspinal C5, T1 roots. Now, which way we will remember them? Remember that same root, different nerves. If you look at the FDI, ulnar has got C8T1 in FDI, and APB, this is median C8T1. So you are different nerves, but same root you are doing the EMG in here, right? And same root value, different nerves, median C6 and C7, radial C6 and C7, you see triceps and flexor carpi radialis. So same root value but different nerves, and here you have same root, different nerves, ulnar and median. Here same root, different nerves, median and radial, and now different root values but same nerve, that is median nerve, flexor carpi radialis, and abductor pollicis brevis. This is median C8T1 and C6, different root value but the same nerve. So that's how you have to remember. And same root value, different nerves, radial and axillary, deltoid C5, C6, and brachioradialis C5, C6. So same root and a different nerve. So different root and same nerve. So you check out your program of EMG and what muscles you will have to. But one thing is sure, by doing a ulnar and a median and a radial nerve conduction studies, we are not assessing C5, C6 and C7. So EMG, if there is a CMAP abnormality, EMG is a must. And then if you suspect there is a root pathology, and this is the cervical paraspinal EMG which you have to do, and try and look for insertional activity which is abnormal. So a 19-year-old male suffered a road traffic accident 3 weeks ago. He reports dense sensory loss of the medial aspect of the right hand and forearm. Right ulnar medial antebrachial cutaneous snaps are absent. Right median and ulnar CMAPs are also absent. State true or false. The absent right ulnar and antebrachial cutaneous snaps indicate that there is a C8T1 radiculopathy. Oh yeah, that's nice. So yes, it's false. Why? Oh, sorry. I will unmute you people. You can. You are unmuted. Yes. Sensory preserved in radical. Okay. Right. Oh, fine. So the absent right ulnar and antebrachial snaps indicate that this is a C8T1 radiculopathy, right? But this is a radiculopathy definitely, because medial side this is C8T1, this is C8, And second, EMG would demonstrate normal paraspinal and abnormalities in the right lower trunk innervated muscles. It is, will it show or not? It's 3 weeks. So FIPS and positive sharp waves are likely to appear in this case. So this is antebrachial, medial antebrachial cutaneous nerve, which is originating from the C8T1, the lower trunk, I mean lower cord. So it is fitting into a plexopathy, but not a radiculopathy. And right, so it's a false. Is very nice answer. So now the questions will start and we'll interact. Regarding the innervation of the upper extremity, which of the following is correct? The brachial plexus is formed from the posterior rami of C2 to T1. The lower trunk is formed from C3 and C4. Dorsal scapular nerve is the only nerve that branches directly off the nerve roots. The middle trunk is formed from the C7. The cords of the brachial plexus are named according to their anatomic relationship to the subclavian vein. Which is correct? Which is correct?
Fourth కదా.
Middle trunk? Okay, that's nice, excellent. So let's just look at the trunks and the trunks, the ventral rami of C5 to C1 nerve roots. The upper trunk is C5, C6 nerve roots. It has two branches, and as we have seen in the diagram, suprascapular nerve, which supplies the supraspinatus and the infraspinatus and the nerve to subclavius. The middle trunk is a C7 root. There are no branches from the middle trunk. The lower trunk is C8T1. There are no branches from the inferior trunk. So the trunks then divide into anterior and posterior. The only trunk that has branches is the superior or the upper trunk. And let's a bit about radiculopathies we'll see, because this is an important aspect. C6 sensory loss over the lateral thumb, the lateral forearm, and the motor weakness in the forearm flexion and supination. And what are muscles? The C6 motor, C6 supplies subclavius, supraspinatus, infraspinatus, biceps brachii, brachialis, deltoid, teres minor, brachioradialis, all have got C6 fibers. C7 sensory loss or the third digit, that we all know that, and you remember that C5, C6, C7, C7 motor weakness in triceps and latissimus dorsi. So if it is pronator teres, then C6, C7, C7, C8, flexor carpi ulnar wrist, and flexors and extensors of the wrist. This is only to sensitize you that you remember these in whichever way you like. We are going to revise a bit about cards also. The posterior card is formed by posterior divisions. As you know, this is the most easiest to remember, that upper, middle and lower trunks. Yeah, that there is some charts coming. Yes. Oh, okay. Right. Very nice. There are three nerves arise from the posterior cord. The upper subscapular nerve, which has got a C7 and C8 fibers, subscapularis muscle. The lower subscapular nerve, C5 and C6 teres major, lower part of the subscapular. These both muscles, they adduct the shoulder. The thoracodorsal nerve, which supplies the latissimus dorsi, which is also extension of the shoulder along with external rotation. The posterior cord ends in two nerves, the axillary nerve and the radial nerve. Okay. Now the lateral cord anterior divisions of the superior and middle trunk, that is C5 to C7, it's got a lateral pectoral nerve, which we have seen in the diagram. The pectoralis major it supplies, and it has two nerves. The median nerve, which also receives a contribution from the medial cord, the musculocutaneous nerve, and the lateral antebrachial cutaneous nerve. Now the third is medial cord, which is a continuation of the lower trunk, which you have seen. The medial pectoral nerve, the medial brachial cutaneous nerve, the medial antebrachial cutaneous nerve, which is innervation to the medial forearm. The medial cord gives fibers to the median nerve and then continues as a ulnar nerve. So that diagram you just remember, and that diagram will really help in memorizing things, because these things will get murkier and murkier, and in exam it becomes more murkier. And these are the roots, these are the trunks, these are the divisions, these are the cords, and these are the terminal nerve branches which are seen. And you remember that 4 trees which we have drawn, and that dorsal scapular nerve, suprascapular nerve, right, and a lateral pectoral nerve in the C5 and C6, right. Which of the following is correct regarding the median nerve? The median nerve arises solely as continuation of the medial cord. The median nerve carries C2 to T5 fibers. It innervates all forearm extensors. It innervates all intrinsic hand muscles. It does not innervate any muscles above the elbow. Which is correct of this? Any answers coming? Yeah, that's one. Right, right, very nice. So, does not innervate above elbow. That's excellent answer, and you are really following well. So let's read about a median nerve is derived from the lateral and medial cords. It does not innervate any muscles in the upper arm. The median nerve runs down the midline of the arm and crosses over the brachial artery to lie just medial to it as it passes under the bicipital aponeurosis in the antecubital fossa. We'll have another question in the coming slides. In the forearm, the median nerve innervates pronator teres, flexor carpi radialis, and flexor distorum superficialis, and these are the muscles which are innervated by the median nerve. And in the forearm, the anterior interosseous nerve that innervates the flexor distorum profundus, second and the third digits, flexor pollicis longus, and pronator quadratus. Before entering the carpal tunnel, the median nerve gives off the palmar cutaneous sensory nerve. That's why in carpal tunnel syndrome you don't have any sensory loss in the palm. Then it passes through the carpal tunnel and gives off the thenar motor branch, which innervates the abductor pollicis brevis and apponens pollicis, and also innervates the the lumbricals and first and second lumbricals. And then where is the median sensory? The palmar cutaneous nerve and distal branches, the lateral two-thirds of the palm and the distal dorsal aspect of the first to third digits and the distal lateral half of the fourth digit. So we do test fourth digit in carpal tunnel syndrome, if you remember, but I'll talk about it in a later. But important thing to remember is if you want to test median sensory, that is the tip of the index finger which you have to test. A 62-year-old painful tingling sensations and numbness in her left thumb, index and middle finger that wake her up night. On examination, motor power in the left arm, forearm, hand is normal. There is subtle loss of pinprick and light touch on the distal first to third digits at the fingertips. Biceps and brachioradius deep tendons are normal. So a tracing has been shown here. And what is the diagnosis? What is the diagnosis of this? Yeah, oh, I think you're excellent. Then let's talk a bit about CTS. CTS is a very common thing which we all see. It's the most common entrapment neuropathy. It's bounded. The carpal tunnel is bounded dorsally and laterally with the carpal bones, and the transverse carpal ligament forms the palmar border. What are the structures that pass the carpal tunnel? Include the median nerve that passes superficially, flexor pollicis longus tendon, four tendons of flexor distorum superficialis, four tendons of flexor distorum profundus. And some of the young doctors are in the habit of giving steroid injections. Beware of the contents of the carpal tunnel and whether we are going to harm some of these. It may be unilateral or bilateral, or the symptoms of include pain and paresthesias, especially in the night, and they awaken the patient, and the patient has to shake their hand to relieve the symptoms. Any obscure pain in the upper limb, first you think of carpal tunnel syndrome, and sensation is spread over the thenar eminence because palmar sensory branch that innervates the thenar eminence travels outside the carpal tunnel. What physical examination show? Provocation of symptoms with repetitive tapping on the median nerve or the wrist, that is Tinel sign, and hyperflexion of the wrist for a period of time, phalanx maneuver. So this we have seen. The motor branch of the median nerve distal to the carpal tunnel is the thenar motor branch. In advanced carpal tunnel only, you got thenar muscles are therefore weak and atrophied. But we often see the thenar wasting cases. That means our cases are coming after they are far advanced and they are ready for surgery. And in this case, it is carpal tunnel syndrome. Okay, this is the thing which we follow the diagnostic criteria of CTS. You do a distal motor latency, it should be less than 4.4. Difference between distal motor latency of median and ulnar nerves should be less than 1.1, that is distal motor latency. Difference between distal sensory latency of median and ulnar nerves should be less than 0.2. Difference between median ulnar sensory latencies on stimulating fourth digit and recording from wrist at equal distance should be less than 0.2. Difference between median and radial sensory latencies on stimulating thumb and recording from the wrist at equal distance should be less than 0.4. So these are the things these are the diagnostic criteria. You can make a chart and like we did here, and we can present it to the surgeon, whoever is operating. So regarding the ulnar nerve, which of the following is correct? It innervates several muscles above the elbow. It's a continuation of the medial cord. It is most susceptible to injury at the lateral epicondyle. It passes through the carpal tunnel to reach the hand. Predominantly carries C5 and C65. I think very easy thing, and people can answer this very easily. This is very nice, and I hope everybody is participating. Only one person is answering all questions. Suresh Reddy, only you are answering. What are others doing? Okay, good. That's correct. It's a very simple question. And ulnar nerve, medial cord gives a contribution to the median nerve and then gives off the two branches, and then it continues as ulnar nerve. The medial brachial cutaneous nerve and medial antebrachial cutaneous nerve, which provide the sensory innervation of the medial half of the arm and forearm respectively, are given off by medial cord. Then it continues as the ulnar nerve, which predominantly carries C8 and T1 fibers. So the ulnar nerve does not innervate any muscles in the upper arm. At elbow, it emerges from the triceps and enters the postcondylar groove, a bony canal that is between the medial epicondyle and the olecranon of the ulna, where the ulnar nerve is most susceptible to the injury. It then travels down the forearm, supplies the flexor carpi ulnaris and flexor digitorum profundus fourth and fifth digits. It also gives off two sensitive branches, the dorsal ulnar cutaneous nerve and palmar ulnar cutaneous nerve. And very important is the next part. And some questions are often asked about Guyon's canal. The ulnar nerve then enters the hand via the Guyon's canal, which is bounded by the carpal bones dorsally and laterally, the transverse carpal ligament medially, and the palmar carpal ligament ventrally. It bifurcates into a deep motor branch and a superficial sensory branch distal to Guyon's canal. The deep motor branch, now of course you know that it innervates the hypothenar eminence muscles, abductor digiti minimi, flector digiti minimi, and opponens digiti minimi, and also provides the innervation to many of the intrinsic hand muscles which are largely involved in the fine finger movements, the fourth and fifth lumbrical, dorsal and palmar interossei, two thinner muscles, adductor pollicis, and part of the flexor pollicis brevis. And sensory innervation is to the hypothenar eminence and palmar and dorsal medial portions of the hand, fifth digit and half of the fourth digit. So this is a frequently asked question, the Guyon's canal and the ulnar nerve distribution. And if you look at this, the flexor carpi ulnaris muscle is very important because it carries C7 fibers also, whereas other muscles supplied by ulnar nerve, they are all C8T1, and most of the intrinsic hand muscles are supplied by ulnar nerve. Right. A 40-year-old man presents to the clinic complaining of left hand weakness. He complains of significant loss of fine motor coordination in the left hand. On examination, he has atrophy of the intrinsic hand muscles and weakness of the wrist flexion in an ulnar direction. Flexion at the distal interphalangeal joint of the fourth and fifth digits, and abduction and erection of all the fingers. There is loss of sensation or the hypothenar eminence in fourth and fifth digits, but more proximally proximal arm muscle strength, forearm flexion, pronation, flexion of the second and third digits at both proximal and distal interphalangeal joints are of normal. Thumb abduction is mildly weak. On attempt to make a fist, there is hyperextension at the MCP joint of the fourth and fifth digits and flexion at the proximal but not distal interphalangeal joints. Ulnar nerve C maps are shown here. We'll show you this. And where is the problem? What do you call this observation here? Anybody can tell? What are you seeing the C maps of ulnar nerve? What is interpretation? Yeah, yeah, that's good. Medial the conduction block across the elbow. Right, I think Suresh, you're right, and that's no doubt about it. There is a conduction block because the amplitude is fallen by more than 50%. And what is the most likely diagnosis is that there is a neuropathy at or above the elbow. So etiologies of this will be trauma, lacerations, or blunt injury, the significant loss of fine motor coordination because of the weakness of the third and fourth lumbrical muscles, and thumb abduction. You remember, flexor pollicis brevis is innervated by both median and ulnar nerves. So even with complete ulnar palsy, some thumb abduction can still be achieved by cause median nerve also supplies. And we look at the ulnar clawing. When asked to make a fist, the hand assumes the appearance of a claw with fourth and fifth digits hyperextended at MCP joints and partially flexed at ICP interphalangeal joints. This occurs because the third and fourth lumbricals as well as the interossei flexor digiti minimi are weak, and there is unopposed action of the radial nerve innervated muscles causing hyperextension at the metacarpophalangeal joints. So the Wartenberg sign is the fifth digit involuntary abduction at rest due to paralysis of the third palmar interossei with unopposed action of extensor digiti minimi and extensor digiti digitorum communis, which are radial innervated muscles. That is one sign which you should remember. That is the Wartenberg sign and Froment sign, whereby during attempted forceful adduction of the thumb, as with the attempt to hold a piece of paper between the thumb and the index finger, the thumb flexion occurs. This occurs because adductor pollicis is weak, and thumb flexion by the flexor pollicis longus is the compensatory action, which this test is frequently done in our OPDs. And this Froment sign and Wartenberg sign are very useful tests for to remember. And which of the following is correct regarding the radial nerve? It carries CAT1 fibers. It innervates strictly the forearm extensors. It contributes to triceps innervation along with the median nerve. It provides sensory innervation to the medial arm and forearm. It is a continuation of the posterior cord. And I think already people have said, I think, yes. So thumb abduction is by abductor pollicis brevis. Why will it be affected in ulnar neuropathy? No, thumb abduction. Abduction is weak, no? Oh, thumb abduction. Flexor pollicis brevis is also innervated by both median and ulnar nerve. It has got some abduction action also. So abductor pollicis brevis, and yeah, I think I made a mistake. You are correct. This is thumb flexion. But there is some abduction also is preserved. That's what I read. But anyway, we'll check back this. Okay, right. Oh, that's nice. Sensory innervation to the this is of course easy question, and this is a radial nerve. It's a continuation of the posterior cord C5, C6, C7, C8 fibers. The first branch of the radial nerve is the posterior cutaneous nerve to the arm. In the arm, the radial nerve gives branches to long, medial, and lateral heads of the triceps, and because it's the sole innervator of the triceps, and then travels along the spiral groove. It then gives of the posterior cutaneous nerve, which runs with the radial nerve in the spiral groove of the humerus. In the spiral groove, the radial nerve gives of the lateral cutaneous nerve to the arm. Distal to the spiral groove, it gives branches to the brachioradialis, a forearm flexor, extensor carpi radialis longus, and brevis, and that beat muscles which we have read. Distal to the elbow, it bifurcates into posterior interosseous and superficial sensory radial nerves. The posterior interosseous nerve syndrome is very important in exam. It often comes. It innervates the extensor carpi ulnaris, extensor digitorum communis, extensor digiti minimi, abductor pollicis longus, extensor pollicis longus and brevis, and extensor indicis. So this is a important nerve to remember. Posterior interosseous nerve syndrome is often asked. The radial nerve provides a sensory innervation to the posterior arm, to the lateral arm, and to the posterior forearm also, and dorsolateral half of the hand, the proximal two-thirds of the thumb, which I have shown in the diagram, including the lateral thumb or the anatomic snuff box. And actually, that anatomic snuff box testing is the indicator of the radial nerve sensation, the second and third digit superficial sensory radial nerve. And so these are the radial nerve innervated muscles, and you can note them and remember them for your EMG purposes. A 52-year-old truck driver, since his teenage years, presenting with tingling in the fourth and fifth digits of his left hand. The tingling is mild but annoying to him. On examination, there is reduced sensation to all modalities on the dorsal and palmar aspect of the fourth and fifth digits from the wrist crease to the fingertips, with preserved strength in all muscle groups. So, which of the following statements is correct? The man has carpal tunnel syndrome. Ulnar neuropathy at elbow. Should be referred to a surgeon. EMG is expected to show fibrillation potentials in the C6, C7 myotomes. Conservative management frequently fails in this type of disorder. So, what do you think is the correct answer in this question? So, any answers? Yeah, that, I think Suresh will answer this question. Yes. Rajalakshmi, two. Allah neuropathy, yes. You are correct. And, so this ulnar is most successful, susceptible to the entrapment at the postcondylar region. This type of compression is best managed conservatively with the avoidance of pressure on the elbow, and that's a wonderful answer. So the 73, I think we'll have one or two questions more. It's already 8 o'clock. Last question. A 73-year-old man with poorly controlled diabetes presents with complaints of painless weakness of the extension of the fingers in the left hand. On examination, forearm extension, wrist extension, abduction, that a wrist extension in a radial are normal in strength, but wrist extension and adduction, that is in the ulnar deviation, are weak. Forearm supination is weak, particularly when tested with the forearm extended, but there is no pain with active supination. Finger extension at the MCP joints is also weak, as is thumb abduction in the plane of the palm, thumb extension at the interphalangeal and metacarpophalangeal joint. So all the extensors are involved. Sensory examination is normal. On nerve conduction studies, the superficial sensory radial nerve is normal. Triceps deep tendon reflex is normal. And what is the most likely diagnosis? I want to go back to the question because since this is the last, yeah, already somebody has said that. Yes, nice. What is the answer? Third, that yeah, posterior introsseous. And I've been stressing on this a lot, and because this has appeared a couple of times in exam, so you should know about posterior introsseous nerve palsy. It can happen in diabetic mononeuropathy, posterior introsseous nerve compression due to lipomas or nerve sheath tumors, or the brachial neuritis, which can affect single nerves also. There is no obvious wrist drop because radial nerve branches to the ECR, extensor carpi radius longus, and brevis proximal to the posterior introsseous nerve origin. There is, however, weakness of the wrist extension in an ulnar direction. Strength of more proximal radial nerve innervated muscles are preserved, that is, beat muscles. Superficial sensory nerve responses are also cutaneous or preserved, and intact triceps reflex and normal strength of the forearm extension. So that's all from my side today, and we tried discussing the peripheral neurology of brachial plexus. We tried drawing the diagram, which is useful for examination purpose. We learned a few things, and I think anything else, any questions? Because already 8 o'clock, we have finished 1 hour our time. Students, anything you want to say? You're all, yeah. Any questions? Uh, Hello? Unmute. First unmute. Yes, and shall we say bye bye? Good night. Till next. I think I would like to take on dementia. So how about what will you say? Shall we do dementia for some time? Hello. What topics which will be interesting to you people? You can write. Somehow it's not getting unmuted. Somebody can type. Treatable dementias. Okay. It was very helpful, and I think yes, dementia. Actually, mostly treatable dementias, Soumya, is 10% of the whole dementia. So you have to know the assessment of dementia. So I think we'll talk about clinical assessment for dementia. Okay then. Good night. Have a good weekend. See you next week. Bye. Good night.
వాళ్ళు ఫ్రైడేనా
Yeah.
మేడం క్లాస్ థర్స్డే ఉండేది కదా మార్చి వీరమ్మ మేడం